My name is Riley Turner and I'm a student at South Tahoe High School. For this unit, I chose to do my project on post-surgical rehab for patients who underwent a fasciotomy after suffering from compartment syndrome. In order to understand the physiology of the syndrome, we must first acknowledge the anatomy of the lower leg. In the lower leg, there are four compartments: the anterior, lateral, deep posterior, and superficial posterior compartments. The bones of the lower leg, including the tibia and fibula, the interosseous membrane, and the anterior intermuscular septum, are the borders of the compartments. The anterior compartment includes the tibialis anterior, extensor hallucis longus, extensor digitorum longus, tibialis anterior, and the deep peroneal nerve. The lateral compartment includes the peroneus longus and brevis, and also the superficial peroneal nerve. The lateral compartment includes the peroneus longus and brevis, and also the superficial peroneal nerve. The deep posterior compartment includes the tibialis posterior, flexor hallucis longus, flexor digitorum longus, popliteus, and the tibialis nerve. The superficial posterior compartment includes the gastrocnemius, soleus, plantaris, and the sural nerve. All of these compartments are surrounded by fascia, which does not expand. Compartment syndrome of the lower leg is a condition where the pressure increases with a non-extensible space within the limb. This compromises the circulation and function of the tissues within that space as it compresses neural tissue, blood vessels, and muscles. With complications, this condition may result in necrosis due to compression of blood vessels, as well as disruption in circulation and ischemia if not diagnosed and treated properly. There are two types of compartment syndrome: acute and chronic exertional compartment syndrome. Acute CS can be caused by injuries such as fractures, blunt trauma, or a reperfusion injury after artery obstruction, such as in crush injuries. Chronic CS is a common injury in young athletes, causing pain in the involved leg compartment during strenuous exercise. It clinically manifests by recurrent episodes of muscle cramping, tightness, and occasional tingling sensations. Unlike most injuries, this injury does not respond to anti-inflammatory medications or physical therapy, which makes surgery one of the few viable options. A fasciotomy is a limb-saving surgical procedure where the fascia is cut to relieve tension or pressure to treat the resulting loss of circulation to an area of tissue or muscle. Fasciotomies of the lower leg typically are used with a 2-incision technique or a single lateral or medial leg incision. The surgery will result in a long open wound that will remain open immediately following surgery to prevent the syndrome from recurring. A wet to dry dressing or wound vac will be placed over the surgical site until the compartment swelling has decreased, usually 48 to 72 hours after surgery before closing. There are 4 wound closure techniques for a fasciotomy. First is a delayed primary closure where normal sutures close the wound. Split thickness skin grafting allows for immediate wound coverage but could require multiple operations and further scarring. Another method, where tissue is expanded by continuous traction, slowly moves the skin back into place through sutures or wires and may take a couple of days. Lastly, A-cell treatment is when a powder of stem cells obtained from pore-flowing urinary bladder is sprinkled onto the wound. This is especially helpful in cases where a skin graft cannot be obtained, such as in children or elderly patients. Following surgery, recovery time will take anywhere from 4 to 6 weeks, while rehab will persist anywhere from 12 to 16 weeks after the operation. Patients will be on crutches and partial weight bearing for the first 2 weeks. During this time, active range of motion of the hip and knee is encouraged, as well as gentle motion of the ankle is tolerated. Ice and elevation will help to prevent further swelling, and upper leg stretches and straight leg raises will prevent atrophy. Weeks 2 through 4, the patient will no longer need crutches and will progress to weight bearing as tolerated. The goal for this phase is to get the patient comfortable with dorsiflexion and plantar flexion with active range of motion within normal limits. The patient should do gentle dorsiflexion stretches with a towel, as well as ABCs, towel crunches, pain-free leg and calf raises with 25% body weight, and should ride a stationary bike with no resistance. If swelling is persistent, a compression stocking is advised with continuation of ice as needed. Weeks 4 through 6, previous exercises will continue with the addition of scar massage if the incision is fully healed. The goal for this phase is to be able to complete 10 single leg heel raises and maintain normal walking gait for a minute. Exercises include TheraBand with resistance, wall sits and mini squats, double leg heel raises with progression to single leg, and walking forward and backwards on a treadmill. Weeks 6 through 12, the patient should continue previous exercises with the inclusion of a progressive strengthening and low-impact cardio program. Goals for this phase includes 30 to 45 minutes of low-impact cardio 5 times a week and to have strength of injured leg be at 90% of the non-involved leg. Exercises include the leg press machine, knee extension and hamstring curl weight machine, and push-up sit-up progression. Weeks 12 through 16, the patient will continue previous exercises and will begin a running progression after they complete 3 sets of 20 heel raises with injured leg strength at 90% of uninvolved, complete a pain-free 2-mile walk at 15 minutes a mile, and if there is no post-exercise swelling. If the criteria is met, the patient can then do agility drills and transition to normal activities. In the end, while chronic cases of compartment syndrome can be handled without surgical intervention, the only viable option for acute CS and severe cases is a fasciotomy surgery. After following the rehab program, patients should be at or close to where they were before the injury no later than 1 year post-op.